I am actually the case presentation today. So I was at a BYU football game, and they were doing the Simba cam, going around the stadium where everyone was holding their babies, and I was standing next to my 5-year-old nephew. He's like, "Uncle Gary, put me up. We'll get on the camera." And so I was like, "Sure." So I grab him, and I'm holding my what felt like 150-pound 5-year-old nephew up there. And of course, there's a opposing fan next to me, and he has his much smaller baby, and I can see that he is struggling to hold his baby up. And I'm like, I am gonna beat this opposing fan, and it's gonna lead to our victory in the game. And so I am holding my nephew up, and I waited until he dropped before I dropped, my nephew down on the ground. And since that time, my right shoulder has been on fire. So I'm coming to you. I've had the Confundus charm or whatever from Harry Potter. I have no other memory other than just my shoulder. So I'm coming to you guys. What sort of questions do you have for me about my shoulder pain? How can we get this figured out? Ready, go. What's your question? On the side here. That's a great question.
Does it radiate down the arm?
Yeah, like down into the deltoid. Oh, I don't know that word. Down into my shoulder. There isn't radiation like down into the hand. That's a great question. Oftentimes, like bicep will radiate all the way down along the track of the biceps tendon. Some obviously cervical compression pain can radiate down into the hand. What other questions? Yeah.
Any numbness, tingling?
No, that's a really good question. Yeah.
What weights are most painful?
Anything overhead. So the recreation of said, like anything overhead hurts quite a bit. Yeah, that's a really good question.
Clicks it.
I mean, I don't want to talk about all of those, but yeah, some in the shoulder. It's not like clunky, but sometimes it like clicks or feels a little bit funny. What other questions? Yeah, Lindsay.
Any past history of injury to the shoulder?
That's a really good question. Not that I'm aware of. But, growing up with Johnny as a slightly older brother, I'm pretty sure I got pinned more than my fair share of times to the floor. So, yeah.
Why do you not got a PT?
That's such a good question. I don't know any good PTs. Right back at you, buddy.
So, it says MD on the bottom.
Anything else?
Any winging in your scapula?
Yeah, no, not that I know of. I mean, we could do a test. So that's a really good point. I think that's often something that we overlook when we're examining shoulders is, a really true good shoulder exam includes inspection of the posterior musculature. So, like with the tank top on, like pushing back our shirts off for males, like pushing against the wall. And oftentimes you'll see scapular dyskinesia or like a winging. I don't know that I have any winging, but that's a really good point. Thank you. Anything else?
What happened when you got your injection?
Oh, I didn't get an injection. That's a lie. I just slightly changed it from the previous slide.
Chipper.
But I didn't get an injection just because, I'm just going to tough it out forever and ever and ever. So it's been hurting now. When did we play Kansas State? Like 6 months ago. It's been hurting decently for 6 months. So what should I do about this? Right?
Do any imaging?
Oh, such a good question. No, these are not mine, but no, I don't have any imaging. Carolyn, what's your initial thought for imaging? What are you trying to?
So if I have never seen the patient, before they come to clinic, I would just have them come with x-rays. Someone says my shoulder hurts, I have them come with x-rays and then examine them, typically before moving to advanced imaging.
Sure, yeah, absolutely. Agree. So here's a theoretical set of x-rays, really not not too bad. Now what? How are you going to help me figure this out? Because the radiology read, no findings, correlate clinically, right? So normal shoulder, now correlate clinically, because they always say that. So what's our correlate clinically? What are we doing? How are you going to figure my shoulder out? I mean, you could reverse slides to the title and figure I might be talking about rotator cuff, or
Yeah, it's physical exam, right?
yeah, this is like the mailbox question. How do you figure out what's going on with your neighbor at the mailbox, right? And what kind of things are you doing? Physical exam maneuvers. What do you want to know? Yeah. Yeah, absolutely. And so how do we test, so 4 rotator cuff muscles, right? How are we testing each of those, right? So yeah, supraspinatus in line with the scapula, thumb down, right? And then, yep, like biceps speeds, Jurgensen's test. Infraspinatus, I have them lock their elbow at the side and I have them actively, and they all do that every time. So you're like, rotate, right? And I'll typically take them through the motion. That's how I've found more efficiency. I'm like, I want you to rotate like this, keeping your elbow here. And then, right, that's infraspinatus. Subscapularis is hand on the belly and pull off. You can do a lift-off test where you lift off the back, but even on my right side, that actually kind of hurts. You can do a lift-off test. I find when patients are in a ton of pain, a lift-off test is a little bit tough to examine. The other thing so that's for subscapularis. The other thing for subscapularis, and this is actually a question on my boards, is increased external rotation compared to the other side is a sign of a subscapularis tear. And then, like for teres minor, which is the forgotten rotator cuff, kind of like me and our family, I'm like the forgotten child. So teres minor is the hornblower. So you're externally rotating here against resistance. So the hornblower's test. So yeah, great. So my exam, everything hurts. You know, the classic like exaggerated
Well,
movement.
so
But
palpation could be helpful in this, right? You want to make sure there's
Yeah.
no significant AC joint or
yeah, and where are you palpating?
initially.
Yeah.
So I kind of start medial at the
Good.
clavicle and go out to the AC.
Perfect.
And then, specifically, you could do like cross body and resisted extension,
Uh-huh.
all of those, and then biceps tendon. You're just following up in like the groove
Yeah.
and palpating the biceps tendon.
Yeah, so tenderness over the biceps tendon, cross the acromion ridge down. Okay, so a little bit of tenderness to biceps. You know, my strength is really retained, but a little bit painful. What other exam maneuvers do you want to know? Yeah, absolutely. So, you know, forward flexion, and then difference between active and passive, right? So I usually have them start actively, and if they can do it all active, then they can, by definition, do passive, and so that I don't have to take them through the whole thing. But if they can only get here actively, it's a very different treatment if there's a difference between active or passive, or if they're just stuck here. Yeah, great. What else?
I like to do an abduction with the arm and see if there's a coupling motion of the shoulder blade
Uh-huh.
to see if there's any impingement syndrome.
Yeah. Impingement, or kind of like a scapular dyskinesia, right? Like things just aren't moving right. Like there's this like 100 to 120 degrees here, and then your scapula, the rest of the motion up here is like through your scapula, tilting the glenoid up. Yeah, good. Any other physical exam maneuvers?
If you're trying to tease out biceps, you would do O'Brien's as a good test.
Yeah, so I like O'Brien's, thumb down, pushing down, and then that typically lights them up over their biceps tendon. If you flip the thumb up, the biceps tendon is attached to the radial tuberosity, so thumb down naturally stretches that biceps tendon, and then as you rotate the thumb up, it relaxes a little bit on the biceps tendon. So if there's a difference thumb down to thumb up, then I have high suspicion for proximal biceps pathology. The other thing is I get them into it's called like a Mayo shear, like back here, and that'll typically really hurt the biceps tendon. And then as you rotate their arm, again, it's the radial tuberosity. As you stretch the arm, sometimes literally you can hold them up and then turn their pain on and off just by moving their wrist. And it's probably important to do twice. I usually do it because it's kind of fun 3 or 4 times, but
Since you had some popping and clicking going on, I'd love to feel what your joint play is like. Is it unstable? Is it tight? You know, where
yeah. And
restrictions or non-restrictions?
what's your go-to method to do that?
I usually, a couple things. You can do like a load and shift test if they're in a sitting position, anterior, posterior pressure.
Yeah.
I often lay patients supine and have their arm abducted and just apply PA pressure in posterior, inferior.
Yeah. And I think, yeah, getting a sense for how compliant their joint is, I think is really critical in treating shoulders. You know, a ligamentously lax Baton score of 7 out of 9 is a very different like treatment than someone who's 65, diabetic, like adhesive capsulitis, and like they can barely move, but may also have some. So yeah, absolutely. Trying to get a sense of the play that they have, I think, is super important. And when you're Scott, when you're doing that, what's your like key to get them in the right position? Like, how do you? Because you have to like pin the scapula, right? And so because if you just move their shoulder back, you're going to move, right, the scapula and the shoulder. So what's your technique for making sure that the scapula is not moving and you're getting true glenohumeral motion?
That's one of the advantages of doing it when they're in supine. They're laying on their scapula, so
Yeah.
it's going to be pretty stable there.
Yep.
So they don't like to relax, especially when they're sore.
Yeah.
So you may have to play with just positioning it a little bit and then easing into a little bit of gliding motion, and then you'll get an assessment.
Yeah, and I pin I like take the clavicle and I like pin their clavicle to the bed too. So using the bed to help you pin the scapula, and then you pin it from the front, and then you're truly getting like glenohumeral motion. Yeah.
Yeah, if you pin them where their scapula is right on the edge
Yep.
of the table, and then you're taking their ball and essentially pushing it posteriorly,
Correct.
and you can block it.
Yeah, it's like finding the right edge to where they're not going to fall off the table, and then you have a worse problem. But the humerus can move, but the scapula can't. And so getting them shifted over, I think, is super important.
The angle of your mobility is important too because of the way the glenoid faces. So you
Yep.
have your posterolateral, I guess.
Yeah. So when you shoot an AP of the shoulder, it's actually like 15 to 20 degrees rotated for the true AP of the shoulder. So when you're translating the shoulder, like if you're going straight back, you're kind of pushing against the glenoid. Like if you remember physics and your vector forces, some of your vector force is straight into the glenoid, and then some is back. And so you want to kind of be cognizant of that angle to kind of push back. Yeah, great, excellent point. All right, so any other physical exam maneuvers? Yeah.
Really physical. You did it already, Bo Brian. You mentioned proximal biceps, but also lateral
Yeah.
maneuvers, which would be tested at the exact same time. If you can't read out for that test. But, yeah, and the only other thing I would mention is on this imaging, you don't have internal and external rotation view. So if you were looking for calcium tendonitis, the only thing this X-ray would be good at wouldn't be shown.
Yeah. Yeah, absolutely. No, the internal and external rotation views show the two kind of footprints of the rotator cuff and show the lesser and greater tuberosities in better angles. And so yes, something like calcific tendonitis you would pick up really well on those type of views. We also don't have a scapular Y here, which shows some pathology. So yeah.
I do think you can see other things on X-ray too, right? Like you can see if there's a high riding humerus. There's a high riding humerus, right? Then you have a really high suspicion for a cuff tear, yeah.
Yeah, absolutely. A lot of times, I don't know if you guys get this too, a lot of times a patient will come in and be like, yeah, your office said I needed x-rays, but I really don't. I just need the MRI. And I think that there's so much to be gained on x-ray. One of those, Carolyn was talking about, the humeral acromion distance here, like 7 to 14 is considered normal, right? Is that, especially in like a supine sitting up x-ray, your deltoid muscle can just overpower a non-functioning rotator cuff. And so the humerus will just start to creep up here as your like rotator cuff muscles start to get weak or partially torn or even tendinopathic. And that distance between right here and right here starts to creep down as like the rotator cuff pathology gets worse. Yeah.
Yeah, sorry, Gary. One more little subtle detail, and I know Scott already one subtle detail sometimes that happens is that posterior capsule can get tight, especially after so much time has to pass. And posterior capsule can be assessed with a posterior glide, and also with hitting down that clavicle, testing internal rotation, see how much motion they have, how much excursion they have. And sometimes if that can get loosened up, it can give you a lot more overhead motion. It takes care of some of that subacromial space as well.
Yeah. And especially with, that's the like known mechanism of like overhead athletes getting like slap tears. Is that posterior capsule gets tight, the humeral head starts to ride up, you start to tear the labrum, anterior, posterior, that's our slap tear. And, you end up examining them and they have like a glenohumeral internal rotation deficit of more than 20 degrees on their affected side. And then, we're just all stretching posterior capsule. And it's amazing if someone has tight posterior capsule, what that will do for a superior labrum tear. It just like takes their pain away, and then we don't have to, unfortunately, do a biceps tendonitis. So that's a fun procedure. Okay, so we talked a little bit about this. This is the humeral acromion distance. This is called the critical shoulder angle. So a lot of what we look at on x-ray tries to help us guide surgical treatment if we ever get there. And so it used to be that basically every time you did a rotator cuff, you trimmed out the spur on the acromion kind of as just a baseline. Everybody got bone taken off of their acromion. And acromioplasty is a pretty painful procedure. And it's probably unnecessary if you have a critical shoulder angle under 35. There probably just isn't too much impingement. So that's one of the things that we look at really closely when we sign a patient up for surgery is their critical shoulder angle more than 35? Because if so, then we consider taking a little bit of bone. The other thing is like the type of acromion that they have. So if they have a high critical shoulder angle and like a type 3 acromion, then I'm more likely to do an acromioplasty. But more often than not, these images are in the normal range, and then we know we don't have to worry about it. Okay, what else on x-ray are we looking for?
So I would look for just spurring out that AC joint.
Yeah.
So you've got superior and inferior spurring.
Yeah. And this one's a comparison. This is not the same shoulder. This is a comparison. This is kind of what a more normal AC joint looks like. This is a pretty arthritic, painful, well, we think potentially painful AC joint. And so
Arthritis is the joint itself.
Yeah, and this is not the best angle, but there is looking to be a little bit of wear and tear. There's kind of an irregular border there. It's not at the exact right angle like we were talking about, like Scott was talking about. But yeah, AC joint, again, is one of those things that I think we used to historically. Every AC joint arthropathy, we're cutting out 8 millimeters of bone off of the clavicle to make space. And I would say more often than not, the patients just aren't painful over their AC joint. And so I'm following, that's where the exam comes in, super helpful. I'm following that AC joint. If I get on the AC joint and push down and they're like, yeah, that's not my pain, and then I do a cross body test and I'm really trying to crank their AC joint, they're like, well, it hurts in the back, or like that hurts deep in my shoulder, but not here. And I do a resisted like extension test and they don't hurt at all. Like there's no chance we're shaving off that distal clavicle. You just run into, if you shave a little bit too much, you can run into instability at that segment and just cause further problem. And I would say, in our practice, 75-80% of the time, there's literally no pain at all. If we think it's involved, if it's a home run that it's involved, I'm pushing down there and they're in a ton of pain, and I bring them over and they're hurting right there, and it's, then we consider it. And if we're on the fence, we typically do a diagnostic. We'll put 2 cc's of lidocaine just in the office right there if we're already signing them up for surgery, right? So we're going in to fix a cuff. We're just trying to find out if we're doing a distal clavicle as well. We just put a couple of cc's of lidocaine into the AC joint, and then we come back 10 minutes later and examine them. And if they're like, yeah, that doesn't really change any of our pain, then even though they're maybe a little bit tender, we avoid it. And then the last thing I think we look for is just glenohumeral arthritis here. So a rotator cuff tear or a biceps tendon issue or a labrum tear in the setting of severe arthritis is just a totally different treatment game and totally different problem. So and like kind of review from the x-ray side, so we look for arthritis, I look for AC joint arthropathy, we look for calcific tendonitis. Unfortunately, on that particular patient, we didn't have an internal external rotation view. I'm looking at, you know, this like little hooked acromion or the critical shoulder angle. I'm looking at the the distance between the acromion and the humerus, and then just kind of the general overall profile. And so hopefully from the last few minutes of discussion, you've kind of seen why we like x-rays so much. If I only had 5 images to look at to treat a rotator cuff tear, right? Yes, I would get a coronal T2 to see how much like retraction of the tendon. I would get a sagittal T1 to see the content of the muscle, whether or not there was a ton of atrophy. And then my other series, I would have a Gracie view, I would have an axillary view, and then I would, you know, try to mix in what I thought was more likely either internal external rotation view to look for calcific tendonitis, or, you know, a scapular Y if the critical shoulder angle was kind of on the border, looking for a hooked acromion. So it's like, of my 5 most important slices, right? You can't have the whole MRI. I mean, you could have 5 consecutive coronal slices. If I only have 5 images to look at, 3 of them for sure are x-ray, right? So order x-rays, please. All right.
Order that series, do they usually cover all those, or do you have that?
Yeah, you can kind of order it as a trauma series that will have an internal and external like rotation view. But yeah, usually a 4 view would be like a AP, like true AP, like axillary lateral scapular Y. And then depending on the hospital and the series, like you can specify internal and external, you know, rotation views. But yeah, they're pretty standard in a 4 or 5 view x-ray. So real quick. So these are 3 different MRIs on 3 different shoulders. And like rotator cuff pathology, when you talk about the treatment, it's all dependent on the cuff. And like this here is an undersurface supraspinatus tear, and it's just partial thickness and degenerative here. And this is just a completely different pathology than this, which is a full thickness, right? Here's the footprint, here's the rotator cuff, full thickness, completely retracted, probably has some muscle atrophy on MRI, and then this is like tendinopathy here. What are you guys doing for this one? So let's pretend this is my MRI. The SimbaCam disaster of 2024 led to a little undersurface, partial thickness rotator cuff tear. How are you guys treating me?
It's like how big?
Like this much.
Like front to back.
Over a centimeter. That's a good question, because, you know, a partial thickness tear, like all the way to the front to all the way to the back, is also different than a partial thickness tear contained over a centimeter. Yeah, good point. What are you guys doing to treat me? Your question was, there you go. What are you doing for me?
Progressive loading is really the biggest thing, looking at all the different modes.
I don't know what progressive loading is.
It's pretty much, where is your baseline?
My baseline is not good, so it's hard to admit that.
So where you start, say everything is painful, you start with isometrics.
Okay.
Get the muscles contracting.
Okay.
Other muscles to calm down their pain.
And in a super painful patient, what's your strategy for getting isometric contraction? What do you do?
So you say you get a wall, you're doing abduction, adduction, flexion, extension.
Okay.
You contract to the percentage where you start to have pain.
So
it might be 10%.
Okay.
You're gonna hold 5 seconds, relax. 5 seconds, relax. If there's a dull ache, less than a minute, we continue. If it's over a minute, we stop.
Okay. And you're strengthening like each of the muscles
Correct.
of the rotator cuff. Yep.
Rotation, all the different directions.
Okay. And then you're trying to walk me
You're starting,
farther and
say
farther.
You're starting at 10%, and you're going to work up to 100%, and then you progress into concentric and eccentric based on how they respond. Hopefully, getting to 100% with all those motions with that symmetric.
Yeah, for sure.
So,
Yeah.
Can I ask you a question?
Yeah.
If you have someone who's super painful and having a hard time participating in PT, do you send them to get an injection so that they're able to better participate?
It depends on how they are perceiving an injection. If they're like, yeah, I don't want an injection at all, absolutely. I love getting injections at the same time. But using the passive modalities, whether it be dry needling, whether it be cupping, whether it be soft tissue work, you got to calm the shoulder down.
Yeah. Yeah, you had your hand up.
A couple different things we can try. Isometrics, I think I totally agree. It's a good place to start. For the really severe cases that they don't tolerate standing up and doing things, they put them on their back, and they would start manual isometrics, and just kind of seeing what pressure it is that they can tolerate without pain. I tell them, okay, you're already in enough pain. Let's do some strengthening that doesn't spike the pain up anymore. And then starting with simple isometrics like that. Shockwave also is a good modality for calcific tendonitis or other shoulder tendinopathies if it's not too severe. But yeah, just trying to calm that pain down is probably the first start.
Yeah. Then, Dr. Chappell, are you doing PRP for this?
Well, if it's less than 50%, there's no retraction. But
Yeah.
we do PRP with physical therapy, because PRP has a tendency to cause broken shoulder.
Yeah.
Nobody wants that.
Yep.
Can I ask you a question?
Yeah.
So there's a comment about a steroid injection. Is that, so I was at the arthroscopy conference last year, and they were all, do not put a steroid in the shoulder if you think you're going to do a surgery. The outcomes are worse.
Worse.
What are your thoughts on that?
Yeah, I agree. It's hard though, because sometimes you have a patient that doesn't have full motion,
Right.
and they are getting physical therapy is brutal, and they hate it, and they just like physically can't do it. So I'll take a slightly worse theoretical outcome in the future, right, and get a steroid injection to get their motion back. I'm not.
Would you put a steroid intraarticular, because that's under surface, or would you put it like versatile?
Both. Yeah, depending on where I think their biggest problem is. If they examine like a slap tear and we can't get them going because they're in too much pain, and most slap tears, if we can get the posterior capsule loosened up, get better, then I'm going intra-articular. If I think this is a, just kind of more of an impingement picture and a partial thickness tear, then I'm doing subacromial. But yes, there's the trend over the last 50, and it's continuing, is to do fewer and fewer steroid injections. I do think to get the patients to work with physical therapy, it's a trade-off.
Sorry, can I ask one more question? I learned so much while I'm here, so
Yeah.
I'm talking a lot.
No.
For physical therapists, if I'm telling a patient to come do physical therapy, what expectations should I set as a timeline for that physical therapy? Because if I tell them 3 weeks, is that sufficient? If I tell them 3 months, is that more realistic?
I think it's somewhere in between. Honestly, like 3 weeks could work if they're participating, if they're excited about it, and have a positive mindset about movement. Your 3 months is probably a little too long. There's a lot of things that could go wrong and south in that time frame, and if we're not making improvement, we're going to send it back sooner than that. So I usually, my guides anywhere between 6 and 8. 3 or 4 visits should get 20 to 30% improvement, and if you're not improving, then there's something wrong, and you should change it up. So that's on us.
But an exam like this, 3, 4 weeks, you should be 50% better.
Right.
Yeah.
So that's really what you're saying. It's like we should be uptrending. It's not like you're better in 3 weeks, you're better in 6 weeks, but you're trending towards 100%.
And when we send up physical therapy for stuff like this, we make a 6-week follow-up. Takes a week and a half to get in, and then a solid month of PT, and then we're trying to assess, probably for us at about 4 weeks, of whether or not this is working or not working. But yeah, I would say, especially for something like this, Dr. Chappell, I would much rather have a patient get a PRP injection. The other thing we run into, though, is that PRP injections rarely, if ever, covered by insurance. It's an out-of-pocket expense, and trying to talk through the logistics of paying, I don't know what the going rate is, maybe $1,000 for an injection that isn't guaranteed to work, but certainly, and especially in partial thickness rotator cuff tears, shows a lot of promising results, and a lot of patients do very well with it. That's maybe the other reason for the steroid is physical therapy will get this better, but but yeah, this one, I'm probably not injecting. I'm probably almost for sure. Again, everything's a probably, because if this guy's on 4 liters of home oxygen and we're injecting this with a steroid so that we can get him out of pain and start to use it. Yeah.
For your MRI, what's the criteria for way to ordering with without contrast or up? Yeah.
That's a very good question. So arthrogram, when I'm looking at the labrum, standard shoulder, basically everything else, biceps, rotator cuff, I'm just getting a standard plain MRI. And in an instability situation, or where I think that there's a capsular tear in addition to a labrum tear, then I'm getting arthrogram. So it's not IV contrast in the shoulder and then doing the MRI. Yeah, great question. So
Patient, with arthrogram, but do we ever order with and without, unless you're worried about cancer?
No, like infection, tumor, whatever is when I do IV with and without for a shoulder. But yeah. And sometimes if they dislocated it yesterday, they're bleeding enough that that's your arthrogram. So sometimes if I get them acutely, I'll just send them without, because it's an acute. So this is a paper that came out about 5 or 6 years ago, and it's a rotator cuff healing index. It's basically, from our side, from the surgical side, which rotator cuffs are more likely to fail and which ones are not. And these are the criteria that they came up with. Age over 70, retraction, size of the tear, amount of fatty infiltration, bone mineral density, and the level of work activity. And some of these numbers are pretty shocking. So if you have basically a score of 0, almost no one has a score of 0, but if you have a score of 1, you're talking about effectively 100% of the rotator cuffs will heal on MRI. So young, traumatic tear, right? These are the kind of ones that will heal. But even when you start to get a few of the risk factors, let's say over 70 and just a little bit of retraction, right? 2 centimeters of retraction, a score of 5, right? Percentage-wise, we're getting up to, flirting with 20%, 30%, 40% as we go down. Right here, half, and then some of these just such poor healing. So one of the things that we've started to do in the rotator cuff world is the augmentation. So biologic augmentation for the rotator cuff. We've gone through xenograft, so animal tissue, and that was terrible. Kind of the current trend is dermal allografts, so skin tissue from a cadaver, and we repair the rotator cuff, and then we overlay the dermal allograft, and that has been a little bit of a biologic game changer, kind of steroid to PRP. We're starting to learn for certain indications, PRP is probably a better treatment. Same thing here for certain indications, right? And so we have a Rohe, this is kind of the Rohe index. So for us, a Rohe score of kind of between 5 and 7, we're considering it. Over 7, we're doing it. On a revision, we're doing it. So that's kind of something that we've added to our practice over the last several years. That's been, awesome. Some of the MRI follow-ups, because I know I've done it, and they have even the slightest bit of pain, and we get an MRI. They're pretty impressive, and we are totally out of time. But anyone have any other thoughts or questions? All right, that's all I got.